you very much. I can't hear you, Shriyan.
Yes, I'm starting on now.
Yeah.
Good afternoon to everyone present here with us today. This is Shriyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker doctor for today's session. Now, with much pleasure and honor, I would like to welcome a very renowned Professor Dr. Rahul Pandit. Sir is FCICM, FJFICM, EDIC, IFCCM, FCCP, MD, Chairman at Critical Care and Emergency Department at Sir H.N. Reliance Foundation Hospital and Reliance Healthcare Initiative. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is sepsis management. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you, Shriyan. Thank you very much for the kind introduction, and welcome to all the viewers today. What I am going to talk over the next 25 to 30 minutes is going to be a very simplified version of the surviving sepsis bundles, which we know, or the surviving sepsis guidelines, which we know of. And then I will be happy to take up some questions if you have anything about specifics about sepsis. But what we are going to cover in this talk over the next 20-25 minutes is going to be evidence-based management of sepsis and septic shock. Okay. So when we say, what is a bundle? You know, a bundle is a group of evidence-based interventions which has components for a given disease that, when executed together, will result usually in a better outcome for the patient. And when you try to do them individually, they may not necessarily look like they are actually giving you the same outcome as what they would give when they are sort of given as a bundle. So I think bundle is something which we have now got used to in our ICU terminology: sepsis bundle, WAP bundle, WAP prevention bundle, a COTI bundle, CRBSI bundle. And that's how we basically look at going across and making a big change in the outcomes of the patients. If we look at sepsis, it's a very old terminology. It's a disease which has been known for us for a long, long time. And no matter what amount of research has gone into it, the outcomes still remain dismal in some of the patients, especially who actually will progress on to have multi-organ failure with septic shock. To improve these outcomes, the Surviving Sepsis Consortium comes out with the Surviving Sepsis Guidelines. And it's a collaborative effect from all the societies across the world to try and come out with comprehensive guidelines which will tell us how the patients can improve with evidence-based medicine guidelines being given. What do guidelines do? Guidelines sort of standardize the care. Guidelines does not mean that you actually have attained the maximum. Guidelines means that this is the bare minimum that you should be doing for a better outcome. Anything beyond that, which can be done and which should be done, should definitely be offered to the patient. So another important aspect about bundles is bundles are time bound. So like any other intervention which you would do, it has importance in a given time. So if you have a particular intervention which needs to be done within the first few hours of the sepsis, then it makes a difference when you do it in that hour itself. If you delay it, the importance of that and the effect which you would get from that intervention would actually disappear. Hence, bundles have been divided in time zones in sepsis. Particular set of interventions need to be completed in those time zones. Okay, so the Surviving Sepsis Guidelines has got different recommendations and bundles for time zones. You've got a 6-hour bundle, you've got a 24-hour bundle. Then in 2015, they come out with a 3-hour bundle and 6-hour bundle. And then they have now got a combining a 3 and 24-hour bundle as to reflect and to have a reflection of the improvement of the care as well as a quality improvement to see what actually makes a difference. So what's the 6-hour bundle? The 6R bundle essentially was centered around measuring lactate, having a presumed diagnosis, blood cultures obtained, and antibiotics, appropriate antibiotics administered within the first hour, immediate fluids to be given, mean vasopressor to keep a mean arterial pressure of around 65, and inotropes of blood transfusion. And the 24 hours bundle was glucose control of less than 8.3 millimoles, which is around 140 millimoles per liter, plateau pressure of less than 30 for patients who were ventilated, the detrogen alpha considered for severe sepsis, steroids given for septic shock, Apache 2 score, and predicting hospital mortality. That was 2004. Since 2004 to 2015, the guidelines have changed and guidelines have improved, and they have sort of got rid of things which were not evidence-based or which subsequently proved out to be not effective. So now they say that in 3 hours, try to measure the lactate, obtain blood culture, administer antibiotics, administer broad spectrum antibiotics, and give 30 ml per kilo of crystalloids for hypotension or a lactate which is more than 4 millimoles per liter. And in 6 hours, you need to have a mean arterial pressure of 65, use vasopressors if required, and in the event of persistent hypotension and serum lactate, you reassess the volume status and tissue perfusion and do your reassessment as per the tables given, which basically talk about dynamic assessment, and remeasure lactate if the initial lactate measure was elevated. This was then condensed into, we realized that in time, 3 hours or 6 hours was still too long for sepsis. So we had to come out with what needs to be done within the first hour. So the first hour bundle now is something which we all practice currently in medicine, in our ICUs, in our emergency departments. So what does it mean? You need to measure lactate. You need to measure blood. You need to collect blood cultures and appropriate cultures before administering antibiotics within that hour. Administer broad spectrum antibiotics. Give 30 ml of fluid of crystalloids for patients who have hypotension or in whom the lactate is more than 4. And you start vasopressors now within the first hour if the hypotension persists during or after fluid resuscitation to maintain a mean arterial pressure of 65. Now, there is another request there that remeasure lactate if the initial lactate was more than 2 millimoles per liter. So now this is where your condensed 1 hour bundle is, and trust me, it can be easily done in this. Now, this is the 2021 latest guidelines which talk about surviving sepsis, and you can see there are several authors there because it's a worldwide consortium which looks at evidence-based medicine practices and guides into these things. India has got a representation there as well. You can see Dr. Professor Yatin Mehta there, who was the IICCM president at that time when the guidelines were prepared. He had represented India as a part of IICCM. So, what's new in 2021, which was not there in 2004, 2006, 2008? What is new? So first and foremost, there is no new bundle. So we sort of stick on to that 1 hour bundle, which seems to be the most important thing, and then just reflect back on your 6 hour bundle and see what else you can add. There are recommendations which include recognition, early care, diagnosis, and treatment of hemodynamic care, ventilation, and additional therapeutic recommendations. So let's find out what's new in 2021 guidelines of surviving sepsis. So the QSOFA score to be used only as one method. Well, there is a strong recommendation now that that when you have survived sepsis, you basically start looking at something like a QSOFA score, which was a strong recommendation which was coming up initially when the sepsis 3 definition came in. Now we know that that should not be the only score measured or only method used to screen these patients. So basically use sepsis performance improvement program for sepsis, use SIRS, use QSOFA, use SOFA. You look at the new early warning signs and you look at the modified early warning signs as well. So that's a very strong recommendation that don't be reliant completely on QSOFA. QSOFA, as you know, has got only 3 aspects to it, and it is not something which has been validated for patients within the hospital. Who are coming to the emergency department, but patients who are in the hospital who need to be shifted to the ICU, I think the QSOFA has got a fair amount of correlation. Then there is a weak recommendation, which says that start treatment early, resuscitation early, and give at least 30 ml per kilo of IV crystalloids within the 3 hours of resuscitation, and use dynamic parameters for assessment of fluid. Now, that's very important. The static parameters like pulmonary artery occlusion pressure or a CVP or just a snapshot IVC diameter does not give you enough information of what is happening in terms of fluid resuscitation. So what now we use is something called as a passive leg raising test, maybe, or a fluid challenge, or a heart-lung interaction using stroke volume variation or stroke or pulse pressure variation to look at dynamic measures of fluid resuscitation and see whether the patient will be volume responsive or not. The other thing which we need to look at, again, the recommendation is weak, is use of capillary refill time. The Andromeda trial showed that capillary refill time was reasonably sensitive. The two blood pressure targets, which was low 65 to 75, we now know that we need to at least keep a blood pressure of 65 millimeters of mercury. If there are lactate levels which are decreasing in the elevated cases, it seems to be showing towards an improvement. And remember to admit these patients in ICU within 6 hours of presenting to the emergency department. Now, which fluid? Balanced salt solutions are preferred, although there is very little evidence to say that they are the ones which should be used. But common sense says that a large volume of saline would actually give rise to hyperchloremic acidosis, and that's why it should be basically avoided. If you have large volume resuscitation in septic patients, perhaps albumin-containing fluid might be of a better benefit. There's a moderate level of evidence for that. What is a strong evidence, though, is do not use hydroxyethyl starch or gelatin. So please do not use hydroxyethyl starch or gelatin as colloids. There's a reasonable amount of data now to say that you are causing more harm than good. The second recommendation is about antimicrobial timing and antibiotic timing. So if sepsis is definite or probable, then you basically divide these patients into two aspects. If it is definite or probable, absolutely administer antimicrobials immediately within the first hour of recognition. If sepsis is a possibility and you're not sure, then you divide them into two things. Shock is present, again, err on the side of caution, give them antibiotic. If the shock is absent, then you do a rapid assessment of infectious versus non-infectious causes of why the patient is ill. And if you feel that this patient is probably having an infectious cause, then administer antibiotics within 3 hours. Vasoactive agents. The first line of vasoactive agent which you would use is norepinephrine. Second line is vasopressin. And third line perhaps could be epinephrine, so on and so forth. In patients with cardiac dysfunction, you still have a recommendation. Again, the recommendation may not be very strong to use dobutamine if the blood pressure provides. Ventilate the patient using high flow nasal oxygen. If they are going to be ventilated on the invasive ventilation, then low tidal volume strategy with a PEEP, optimizing PEEP, either using a PEEP FiO2 table, or there are various ways of looking at optimal PEEP, which is the lowest inflection point, and whatever way you actually are comfortable, just make sure that you have an appropriate PEEP applied to these patients. Traditional recruitment maneuvers have got very poor prognosis, very poor evidence. However, there's reasonable amount of evidence for prone ventilation right now. And prone ventilation not only is a very good way to ventilate and has got evidence of improved outcomes and improved mortality, but also is a very, very good recruitment maneuver by itself. So I think in places where you can prone the patient, there is no role for any traditional recruitment maneuver. Intermittent neuromuscular blocking agents can be given and should be given to facilitate ventilator and ventilator patient dysynchrony, along with reasonable sedation. There are some additional therapies. Additional therapies like corticosteroids, stress ulcer prophylaxis, venous thromboembolism prophylaxis, renal replacement therapy, glucose control, enteral nutrition. All of these things need to be looked into a very, very reasonable way. So let's look at, do bundles improve outcomes in sepsis? Okay. Now this is a study which was published way back in 2005, which looked at compliance with 6 hours and 24-hour sepsis bundle on hospital mortality. And they found that in the compliant group, the mortality was significantly less as opposed to the group in which the compliance was not very good. So when you have a bundle compliance, I think it makes a big difference in the outcome, because you tend to do all the right things which are evidence-based. This is again a cohort study, which basically looks at before and after 1 hour and 3 hour sepsis bundle trials. And you can see that with pathway, the outcomes were much better. The mortality and the probability of survival was much, much higher as opposed to patients who had no pathway. So I think it's better to actually stick on to the 1 hour and 3 hour bundle formula, where your chances of surviving, your patient's chance of surviving are much better rather than not actually having that. So implementing 1 hour and 3 hour sepsis bundle for patients presenting with bacteremia resulted in improved bundle compliance and a reduced need for ICU admission without adversely affecting the antimicrobial prescription. I think that was another important aspect which comes out, that if you do your first 1 hour and 3 hour correct, perhaps the need for an intensive care bed may also be less, and this patient may not go through a complete septic shock profile if you resuscitate them adequately, give them the adequate amount of fluids, and then give them appropriate antibiotics. Perhaps they might actually not need ICU. As you know, ICU is a very precious bed resource, and if the patient gets better with your early intervention, it makes a lot of difference. Now, the problem for bundles is there is an ever-changing definition of sepsis. There is a reasonably low compliance for bundle and protocolized care. Everybody wants to have bundle of their own. Time zero is what is taken into Western world, and all these bundles are written up from time zero. We know that time zero in India is very difficult to predict. Patient might be referred to us from, especially patients who are people who are working in tertiary care, patients are referred to you from some other hospitals. So time zero is obviously lost. And the second problem is that if they're coming from home, we really don't know how many hours the symptoms have been for, as pre-hospital care is not as mature as in some of the other Western countries. More and more evidence is now coming that lactate perhaps may not be as important as we think, though we all know high lactate is bad, and improving lactate is probably easier to say that a patient is getting better. But just because you have a lactate of 3 or 4 does not mean that your outcome is always going to be poor. Fluids are always a controversy. 30 ml, too large a volume to be given over 3 hours. Why should we give 30 ml when the fluid could actually be given half of that volume? Which fluid to give? How rapidly to give it? What are the endpoints? I think that controversy always remains. What remains unchanged is administration of antibiotics. They are the gold standards and they remain unchanged completely. So let's look at sepsis definition. This was the third consensus definition of sepsis and septic shock, which was chaired by Mervyn Singer, where it says that sepsis is a life-threatening organ dysfunction caused by dysregulated host response to infection. Okay, the septic shock basically is sepsis in which underlying circulatory and cellular or metabolic abnormalities are profound enough to substantially increase mortality. So you've got a very clear definition of what is sepsis and sepsis shock. And the terms like severe sepsis and septicemia have now been removed. So let's just call it as sepsis and septic shock. If you look at some of the other compliance bundles, you will basically come to know that a new survey about sepsis shows low adherence to guidelines in sepsis cases, putting patients at risk. Then there is this 2019 article which says compliance to 6 hours resuscitation bundle, a quality improvement international trial among Indian patients, published by Swaroop Raji, and a study to adherence of again bundle in a tertiary care hospital. The problem is mortality of sepsis in India is already high. We really don't know because it fluctuates from hospital to hospital, city to city. And adherence to sepsis care bundle is even poor, even at a tertiary care level. And I think that's the reason why I'm taking this effort today, that there are simple bundles to follow. If we just follow the simple bundles without any problem, I think your outcomes would be much, much better. Now, while you may argue about time zero, I would say time zero is a time of triage in emergency department, or if shifted from another care venue. You basically look at the earlier charts, annotations, And are they consistent with all elements of sepsis or septic shock? And then if they are ascertained through the shock, what would be the time zero, and start your work on from that point of time. I think that's the way to sort of bypass that time zero of the problem. And if you look at a couple of papers, this one from Gajewski, which said that around half of the patients did not exhibit signs of severe sepsis or septic shock. Obviously, at that time in 2010, severe sepsis was a term at triage. An average time for antibiotic administration was just under 2 hours. And unlike trauma, myocardial infarction, or stroke, patients often exhibit non-specific signs and symptoms. And you would be confused at whether this patient is septic or not. And hence, this delay keeps on happening. In Indian context, hospital to hospital variability might come into our time zero as a particular time to be taken of time zero. But however, it seems to make sense that just start from where you think is the time zero most likely to be possibly your first contact with the patient, and start counting. That's the best what you can do. Now, lactate guided therapy. This is a very good paper published way back in 2010 in the Blue Journal, which showed that lactate guided versus non-lactate guided therapy. And obviously, lactate guided therapy had improved outcomes. So we all know improvement of lactate does make a sense. However, there are now several studies which have looked at lactate as such and mortality. And really, it's very difficult to say whether the lactate or mortality correlating to lactate is something which we should be sort of putting our whole money on, or lactate is just one component of the whole cogwheel, and we need to give some importance to it, but not sort of run after it. And this Shapiro et al. Emergency Medicine 2005 talks about mortality of around 4.5% if the lactate level is around 2.9 millimoles. 9% if it is on 3.9 millimoles, and 28% if it is more than 4 millimoles. And around 10 years later, a similar study was done, which shows that 12.7% mortality for lactate less than 2, 19% for lactate between 2 to 4, and 25% approximately for lactate greater than 4. So while the numbers are almost similar, what the story and the whole process is telling you is that high lactate is a bad sign, and you need to look into that. Unfortunately, despite lactate being studied so hard, no study has provided a clear cutoff of lactate level. And lactate does not rule in or rule out a diagnosis of sepsis. However, recommended of greater than 2 is something which we should be measuring. And if it is greater than 2, you need to proceed with the resuscitation, because it is associated with bad outcomes. So something which is very, very clear to us right now. Fluids. As I said, best practice recommendation, it's a weak recommendation. Arise, Process, and Promise trials, the average fluid given was around 2000 ml, which roughly equated to around 30 ml per kilo for a 70 kg person. And that's how this 30 ml per kilo has come. If you compare the 4 trials, the EDIT EGDT, the Process, Arise, and Promise, which were in 2014, and the EDIT EGDT was 2001, you can see that the fluids given within the first 6 hours in early goal-directed therapy group was around 8,000 to 10,000 ml. But in the Process, Arise, and Promise trial, it was less, much less, just 4.5 liters or so, around about that. When you come to around total fluid also, the 3 studies on the right had more or less similar amount of total fluid given, but EGDT certainly gave a large amount of fluid. But they had less vasopressors in EGDT as compared to a higher percentage of vasopressors within the first 6 hours, 72 hours, and so on and so forth. So I think there is a reasonable amount of comparison between the practices done 10 years later, where we tend to start the vasopressin a bit earlier, as opposed to 2001, when we were giving a lot of fluids. While it's important to give fluids, I think 30 ml per kilo probably is an arbitrary number. We need to look at other parameters like oxygenation, comorbidities. These are the things which I would do. I would do a quick lung ultrasound and see if the fluid which I'm giving is leaking out into the lungs. I would take a step back, and I would probably use vasopressors early. We also now have reasonable evidence in form of the study published by Boyd et al. That positive fluid balance is associated with high level of mortality. So my friends, if I have to summarize the bundles, Bundles are a group of interventions which show better outcomes when they're done together. They're time bound. Unfortunately, despite evidence being there, there's a poor adherence to it. And a possible poor adherence is due to ever evolving evidence and perhaps some amount of reluctance to accept the bundles. If we do choose to accept the bundles and go as per the evidence-based practice, I'm pretty sure your outcomes for the patients will be better. Thank you very much, and I'll be happy to take any questions.
Thank you so much, sir, for your wonderful presentation. We do have some questions from our audience if you'd like to take that up.
Sure.
So, sir, the first question is, what are the latest development in sepsis research and how might they impact future treatment approaches?
So I think there are a lot of newer developments, just like cancer, where we are now gone up to receptor level or molecular level. We are now also sort of studying sepsis in a similar way. We are studying sepsis by seeing the severity of sepsis at the microcirculation level. So there are now devices which can help us help us monitor as well as modulate the microcirculation. However, there is no evidence to sort of be brought it into the prime time. There has been always a immune aspect of sepsis modulation which has been tried, and Zygris, which was there, or there are steroids which have been on and off, discussed all the time in sepsis, which actually look at modifying the immune aspect of the sepsis. But unfortunately, none of these studies have actually shown any benefit into it. And a third possible research which is going on is to see if there is any signature gene which can tell us that a particular set of patients are likely to have a particular group of infections more commonly as opposed to other patient group of patient. And so fourth thing, which is now really important, is the diagnostics. And diagnostics, because they have gone into a molecular phase, have improved quite leaps and bounds. And literally within 6 to 8 hours of a patient being sick, in some of the instances, we can actually know the organism as well as the likely resistance to antibiotics as well. So these are the areas where research is sort of evolving, and a lot of it is coming into prime time now.
Thank you, sir. The next question is, are there promising new therapies on the horizon for sepsis management?
So I don't think, apart from antibiotics, anything new is basically been coming and showing its prevalence. However, we do know that there is look into modulating it at the genetic level or at the signature gene level, and perhaps those therapies might be something which future might show us. Certainly, early diagnosis helps. That's the first thing which I would be thinking of.
Thank you. The next question is, what monitoring parameters are essential during the course of sepsis treatment?
What? Sorry, beg your pardon. Can you just repeat the question?
Sure, sir. So the question is, what monitoring parameters are essential during the course of sepsis?
So when you have a patient, I take it that a patient is critically ill and is in the hospital and he has septic shock. In septic shock, ECG, blood pressure, preferably arterial blood pressure monitoring, continuous, saturation, heart rate, respiratory rate, if the patient is ventilated, end-tidal CO2, and an ABG. These are the bare minimum parameters which one should be monitoring. This is what I would say as a basics of improving an outcome from sepsis and septic shock.
Thank you, sir. The last question from our audience is, are there specific patient population for whom a more restrictive fluid strategy is recommended?
So I think that's where the dynamic parameters of fluid resuscitation help. Nowadays, we are looking at two aspects, invasive versus non-invasive. If you have non-invasive, I think echo takes the forefront. You look at the IVC diameter, you look at the stroke volume or a aortic VTI variation, and combine that with your lung ultrasound and see if the lung ultrasound actually makes a difference. And if there is no difference in the lung ultrasound, if there are no P waves, if there are no B lines seen on the lung ultrasound, then you can pretty much safely derive and say that the outcome looks to be seems to be better in these patients, and you can give them more fluids.
Thank you so much, sir, for answering all our questions. Before concluding today's session, any last remark from you?
No, I think my only plea to everyone is that kindly adhere to these sepsis bundles. They are the group of interventions which allow you to at least do the bare minimum for the patient, and don't restrict yourself thinking beyond bundles what you could do for the patient. However, bundles is something which is bare minimum and it's time bound. So try and stick to a time. As soon as you contact the patient for the first time, take that as time zero and start building up from there on. Thank you.
Thank you, sir, for joining us today. With your permission, I would like to conclude today's session.